Welcome back, ladies and gentlemen, to the Your Go-To Doc YouTube channel. I'm Dr. Robert Feldman, board certified neurosurgeon for the last quarter of a century. And today we're going to talk about the sacroiliac joint, why it hurts, and how to fix it. We're also going to mention, by the way, that the sacroiliac joint is technically not part of the spine, but it is closely associated with it. And also that the sacroiliac joint causes symptoms that will often fool patients and doctors into thinking they have a low back spine problem, when in actuality they don't. They have a sacroiliac joint problem. So let's get right to it, the sacroiliac joint. So what is the sacroiliac joint? Well, it is the joint or connection of two bones between the sacrum or tailbone and the iliac bone, which is the bone that you put your hands on your hips when you're standing there with your hands on your hips. So the sacroiliac joint is the joint where the sacrum and the iliac bone connect. Technically, that is not part of the spinal column, but it is something that I have been trained to diagnose and treat, so we're going to talk about it today. The other thing I just want to mention, as I mentioned in the introduction, is that I can't tell you how many times I've been sent patients that have been labeled having a low back spinal problem and have had years of conservative therapies for that spinal problem, maybe even have had injections, and maybe even has had surgery for their low back, treating something that didn't look right on the pictures, but they never got better. So they see me, they're labeled on the schedule as a low back problem, and lo and behold, it's obvious to me they have a sacroiliac problem, and then I prove they have a sacroiliac problem, and we'll talk about how I do that later in the video. And then I fix their sacroiliac problem. And let me tell you, these patients are happy. They wake up in the recovery room and they can immediately tell that that old pain is gone. Granted, they hurt a little bit from the surgery, but not too bad. And we'll talk about that too. So let's take a look at what the sacroiliac joint looks like on a spine model. So this is our spine model here. And you can see these green bones here are the lumbar bones. This last one is the L5 vertebra or level, and the next level down is the S1, sacral 1. So this entire orange bone here is called the sacrum, otherwise known in layman's term as the tailbone, and this white colored bone here is the iliac bone. So the sacrum, iliac, sacral bone, iliac bone, sacroiliac joint. So the connection or joint between these two bones is called the sacroiliac joint, and that's what we're going to be talking about today. Now, a better view of this would be from the other side, and let's spin this around. So here you can see again, orange bone is the sacrum, and the white bone is the iliac bone, and this line here is the sacroiliac joint. And this iliac bone is the same iliac bone that, for example, has your hip socket here for your hip joint, and this pelvic area here is where the baby comes out when a woman has a child. So that sort of leads us into the topic of what is the purpose of a sacroiliac joint? Why don't these bones just show up fused when you're born? Well, it's a regular joint, just like your knee joint, your elbow joint. It's got two bones, a layer of cartilage on each bone inside, and then ligaments keeping that bone tight. Technically, that bone is not supposed to move. It's not like your elbow joint or your shoulder joint or your knee joint. There's no physiologic function for these bones to be mobile in everyday life. However, they are meant to purposely loosen during childbirth. So a female's pregnant, they're giving birth to a child, the hormones change during delivery. These joints actually loosen slightly to just give a little give in this area for the baby's head to get through. So the real purpose for the sacroiliac joint is to slightly allow some give way in there during childbirth. And that is why sacroiliac joint problems are more common in females, and more common in females who have had multiple children. Keep in mind, even if you get a C-section, those hormones still change, that joint still gets loose. And a lot of times that joint will not tighten up after childbirth, especially multiple childbirths, and it gets loose and starts to rub around together. And it's when that joint kind of rubs around together that you get sacroiliac pain. And we'll go talk about that in the next section of the video. So again, Sacrum, iliac bone, sacroiliac joint. That's not supposed to move, but when it does, it hurts. And also, before we leave the models, let's look at another model where the sacroiliac joint, the inside of it, is exposed. And this is just going to give you an idea of how big this joint is and how much surface area it has. So if we look at this spine model here, sacrum, L5, and turn it to the side, you can see this entire surface area here is the sacroiliac joint surface area. This is the part of the bone that touches the iliac bone and is kept tight. If that is rubbing around with the iliac bone, that's going to cause pain. So why does it cause pain? Well, basically you've got two bones that aren't supposed to move very much rubbing around with respect to each other, and then the little nerves inside that joint and in the capsule of the joint get irritated and inflamed because of that excessive motion, and they send a message up to your brain and say, hey brain, we're upset down here, we're rubbing around too much, we're irritated, please do something about it. And then what your brain does, without your permission, is it attempts to stabilize that joint. It attempts to keep it tight. And the way it does that is by tightening up all the muscles around here to try and keep that stable. And it does that without your permission. So not only will you have inflammatory nerve pain from the joint rubbing around too much and the little nerves in there getting irritated, but you're going to have muscle spasm pain that tightens up this whole area. And that can include areas of the lumbar spine, the paraspinal muscles here. It can include the gluteus and buttock muscles in here. It can even include some of the inside muscles of the inside of the pelvis here, all attempting to keep this tight. That's also one of the reasons why people with sacroiliac pain can also have sciatic type leg pain or pain shooting down their leg. It's because all these muscles up here are tightening up, and that can sometimes irritate the lumbar nerves that are heading down to the leg. So when you get sacroiliac dysfunction, you're going to have pain in the joint, pain in the muscles, and possibly pain down your leg, similar to sciatica nerve pain. And that's one of the reasons why physicians and patients can get easily fooled into thinking that they're not having a sacroiliac problem because that's somewhat relatively unknown compared to lumbar spine problems, which are very well known. So a lot of people will reflexively think, oh, I've got a low back problem because of all those spots that hurt. But in actuality, it's not the low back, it's the sacroiliac joint. So let's now talk a little bit about who I typically see that have these types of problems. Well, I mentioned earlier that the sacroiliac joint is really not supposed to move. It provides a little bit of giveaway during childbirth for the baby's head to get through the pelvic canal, but it's not supposed to be loose, and that's why it is more often seen in women who've had children. But I can tell you that I've seen many patients, male patients, with sacroiliac dysfunction or rubbing loose sacroiliac joints, and that's typically in male patients who've had some kind of trauma. Motorcycle accident, falling off a ladder, jumping out of an airplane the wrong way, and they injure the ligaments that make that joint tight, and basically get a loose joint and the same kind of pain that you would get if you were a woman who just had a loose sacroiliac joint from multiple childbirths. So it is seen in men, but typically that's associated with some kind of trauma or some kind of vocation or activity that repetitively stretches or loosens that joint. And remember, ligaments that keep bones to get tight together for joints don't heal very well. So if you tear or stretch a ligament, you don't just put it in a brace or a cast and it heals. Ligaments don't heal very well. So you tear or stretch a ligament, that joint is going to get loose and cause problems. For example, you get a torn ligament in your knee, you can't just put that in a cast. You have to surgically repair that ligament to make the joint stable and tight again. So if you're a man and you fall off a ladder and you stretch those ligaments that make the sacroiliac joint tight, and your sacroiliac joint then gets loose and starts rubbing around too much, you're going to get similar symptoms to a female who's had 3 or 4 kids, and that joint has stayed loose, and that two bones are rubbing around also. So although more common in women, they can also be this problem can also be seen in men. So I just wanted to mention that in case there are any men out there watching this video saying, I don't recall having any children. So don't think that it's limited to females. Sacroiliac joints in males can also get loose and cause symptoms. So now let's move on to the office visit. how does that usually play out when a patient is sent to me or seen by me in the office for a sacroiliac problem? Well, first I would say that typically they are not sent to me for a sacroiliac problem. They're sent to me for a lumbar spine problem, or they're sent to me for back pain, buttock pain, leg pain, or they've got back pain, buttock pain, and leg pain, and their primary care doctor got an MRI or some x-rays or a CAT scan, and there are problems on the imaging that they think is causing these symptoms, or they've failed to have improved with conservative therapies. Or better yet, their imaging shows nothing wrong, but yet they're having all these symptoms, and the primary care physician or referring physician doesn't know where these symptoms are coming from and needs my help to figure that out. There are many, many patients that I've seen in the office that will tell me the story, I've been treating this pain for 5 years. I've had 2 surgeries on my back and the symptoms haven't changed. I've had injections in my back and the symptoms haven't changed. And somehow they found their way to me. So I can also tell you that these patients that show up in my office with sacroiliac problems, they look and sound and feel different than someone who has a lumbar spine problem. They walk differently, they sit differently, they describe their symptoms differently. There is a degree of kind of sixth sense, subjective gestalt kind of feel that you get as a clinician after many, many years of seeing this, where sometimes the patient will walk in, you'll say they've got a sacroiliac problem, and you've barely talked to them, or you haven't even talked to them yet, you just know. So what are those kind of hints? Well, first of all, a patient that walks with a sacroiliac problem often is trying to stabilize their pelvis while they walk. So they'll walk with their hands on their hips, or they'll have a belt or brace around their waist but very, very low where the sacroiliac joint is, as opposed to the higher up where the lumbar spine is. When they sit, they tend to sit leaning over to one side with their butt cheek of the side of the sacroiliac problem off the chair. Whereas a patient with a lumbar spine or a pinched nerve problem tends to shift around a lot, as opposed to staying with one butt cheek elevated off the chair. One of the biggest hints that this is a sacroiliac problem, not a lumbar spine problem, is if you ask the patient to stand up and show or point or describe with their hands where it hurts, they do that very differently. A lumbar spine problem patient will typically take both hands and either place them in the center of their mid-back or lower back and then make circles with their hands, describing where it hurts, whereas a sacroiliac patient will often take a single finger and point to an exact spot. And to see this on a picture, let's take a look at what that looks like. So here you can see the difference between what a low back pain patient looks like and a sacroiliac pain patient looks like. Fairly self-explanatory. The patient on the left is sort of grabbing their back with both arms and hands. Typically will make a circular motion in that low back area, whereas the sacroiliac patient on the right over here is literally pointing to a singular spot on the right side where the sacroiliac joint is closest to the surface of the skin. And if you're looking at and don't ask me why you would be doing this, but if you're looking at a naked person's backside, the sacroiliac joint, that the spot that typically hurts the most, is right where the dimple spots are in the backside, which is kind of right in this circle here, even smaller than this circle. So this is an example of how the patient would describe a sacroiliac problem on the right versus a lumbar spine problem on the left. So now let's look at where sacroiliac joint dysfunction will cause pain. So if we look at this picture, we can see on these diagrams on the left and in the middle, you can get groin pain on the front, and that groin pain is typically more deep inside the pelvis than, for example, the groin pain you'd get with a hip problem. And then here, that sacroiliac area, the buttock area, and then down the leg. Similar distribution on this picture here. And this is a good example to kind of show you where the lumbar plexus nerves go into the pelvis and then form the sciatic nerve here, how close those nerves are to the sacroiliac joint. This is the lowest portion of the sacroiliac joint. Here's the highest portion of the sacroiliac joint. The dimple spot is kind of back in here, but you can see the nerves coming through the pelvis here, close to the bottom edge of the sacroiliac joint. So these are good diagrams to kind of show what kind of pain you can get from a sacroiliac problem, as well as why the legs sometimes hurt when you have hurts when you have a sacroiliac problem. So the patient's in my office. I'm suspicious it's a sacroiliac problem. I look at their lumbar imaging, lumbar spine imaging, and either what I see that are problems on those images don't really match up with their symptoms, or I don't see anything on their images that look bad and it doesn't explain their symptoms. So now I'm starting to think, okay, we've got a sacroiliac problem. What can I do to kind of solidify my suspicion that that's what's going on, and therefore potentially lead to a treatment for this patient? So the next part of that process is the physical exam. So what I'll do is the patient will be in the exam room, and we'll do the usual stuff where, we'll test their strength and their reflexes and their sensation. We'll have them get up and down from the table, get up and down from a chair. But then what you can do that kind of hones in on a sacroiliac problem is something called provocative maneuvers. And these are particular maneuvers that you can do with the patient's iliac bones and pelvis to kind of mimic irritation or reproduce irritation of the sacroiliac joint that is pretty specific for the sacroiliac joint. And these provocative maneuvers, and there are 4 or 5 of them, are just ways to bring out the pain in the sacroiliac joint and get the patient to say, yep, that is the pain I'm talking about. And here are some of those provocative maneuvers, including distraction, thigh thrust, compression, the Faber test, and the Gershen's test. All of these things will aggravate the sacroiliac joint if it's loose and reproduce their symptoms, and this is what these look like on an image. So these are examples of provocative maneuvers designed to bring out sacroiliac joint discomfort in patients who have sacroiliac dysfunction. And you can see the examiner is simply putting pressure on various points in the pelvis or manipulating the limbs to bring out pain in that joint. I typically like to have a patient have at least 2 out of the 5, maybe 3 out of the 5 reproduce symptoms. Typically, all of them will reproduce the symptoms in the patient. But this is a nice way to confirm that the symptoms are coming from the sacroiliac joint. And oftentimes, insurance companies will actually require that this be documented, that these maneuvers actually reproduce symptoms in order to approve treatment for this. So again, the 5 provocative maneuvers to bring out sacroiliac discomfort in the setting of a loose sacroiliac joint. Okay, so now I'm even more convinced the patient has a sacroiliac problem. They're acting it like they have that. They point to the spot that I typically see it hurts when they have that. The 2 or 3 of the provocative maneuvers reproduced their symptoms. I don't see anything on their imaging that can really support their symptoms, on their lumbar imaging that can support their symptoms. And that brings up another point. A lot of people say, well, should I get pictures of the sacroiliac joint? And to be honest, the answer is usually no. Number one, pictures showing a problem or not a problem in the sacroiliac joint aren't going to really change my opinion based on all the other evidence I can gather. And second, typically you're not going to see abnormal qualities on X-rays, MRIs, or CAT scans of the sacroiliac joint. There are many people that will show degenerative changes in the sacroiliac joint that have no sacroiliac symptoms, so that doesn't help. This is not really a nerve pinching problem. It's not really a broken bone problem. It's a looseness problem. And imaging does not really pick up that looseness. And there really isn't any kind of dynamic or motion imaging that are going to pick up the amount of movement that can cause pain for sacroiliac problems. It takes very little movement to cause that pain. So you don't have to actually see blatant instability in the sacroiliac joint. It can just be micro motion in that joint that can cause these symptoms. So imaging is not really helpful to prove you have a sacroiliac problem. So anyway, getting back to it, I'm pretty suspicious at this point based on all the history and physical exam evidence. But for me, that is not enough to tell the patient, yes, this is coming from your sacroiliac joint. Could I be fooled and it's coming from the lumbar spine? It's possible. Could I be fooled and it's coming from the hip? Yes, it's possible. Could it be referred pain from something in the pelvic area, in the pelvic organs? Yes, it's possible. So there's one final thing I will do before I'm willing to tell the patient, yes, I'm sure that's where your pain is coming from, or before I'm willing to tell the patient I'm willing to fix it, and that is diagnostic injections. So let's talk a little bit about what that means. So I tell the patient after their office visit, I think you have a sacroiliac problem causing your symptoms, but I want to prove it. I don't want to recommend a treatment for something that's not causing your pain. So I will tell them I'm going to send them for a CT-guided diagnostic sacroiliac injection. And that is usually done in a hospital or radiology imaging center by a radiologist, not me. And what I'll do is I'll send them to the hospital or a radiology imaging center, and I will put them in for a CT-guided injection in the sacroiliac joint. And what they'll do is the radiologist will bring them into the CT scanner, and this doesn't really require any kind of sedation. They may numb up the area where the needle goes in, but they will use the CT scanner to guide a needle into the sacroiliac joint. And this is what it looks like. So this is what a sacroiliac injection looks like on a CAT scan image. This is an actual image from the CAT scanner. This bone here is the iliac bone. This bone here is the sacral bone, and this space in between them is the sacroiliac joint. I can tell you this is a relatively wide sacroiliac joint, so I'm not surprised this patient is having sacroiliac pain. But there is a ligament covering this joint, and the needle, which you see here, which is this white shadow pointy thing looking here, pokes through the ligament into the joint, and that's where the numbing medicine gets injected. And I actually like to see the actual image to show that the needle was correctly in the correct sacroiliac joint. So this is what the radiologist will actually see on the CAT scanner when he is putting the needle into that joint to inject the medicine. So that injection is typically with numbing medicine. I usually will sometimes request that they also put in some steroids for longer lasting relief, but the object here is to diagnose the problem, not necessarily treat it. If, for example, the patient says, look, I'm not ready to consider surgery yet, or I'm not ready to consider surgery for another year when I retire, or my kids graduate high school, whatever, then I might say add some steroids to give longer lasting relief. But the real medicine I'm interested in is the numbing medicine. Typically it'll be some long lasting numbing medicine like bupivacaine or something like that. So they confirm the needle is in the sacroiliac joint. That'll often be with the CAT scanner. They may inject a little dye in there to make sure they're inside the joint capsule, and then they'll inject the numbing medicine. And that numbing medicine will pretty much kick in right away, usually immediately. But it doesn't last. So what I'll usually tell the patient is before the injection, go rile it up. Go walk up and down some steps, rake the yard, chop down a tree, whatever. Get that really symptomatic and hurting, and then pick a number 1 to 10, 10's the worst, and rate how much it hurts. Then after the injection, immediately after the injection, what number out of 10 is it bothering you? 4 hours after the injection, what number out of 10 is it? 8 hours after the injection, what number out of 10, et cetera, for about 24 hours of recording. And then I'll bring them back in the office and I'll say, well, did it work? Now, a lot of times what they'll say is, no, doctor, it didn't work. I'm hurting just as bad as I was before. I'll clarify with them, I understand you may be hurting as bad as you were before, but the numbing medicine isn't supposed to last. So I'm really interested in the first 24, maybe 48 hours after the injection. How did you feel? And then they say, oh, doc, well, that's different. I got off that table and I felt fantastic, and I could move around and not hurt like I have been for the last 5 years for about a day. that is a positive test to me. That tells me that I have proved that the sacroiliac joint is causing those symptoms, because that numbing medicine is captured and stuck inside that joint. It can't move out into their lumbar spine, it can't move over to their hip, it can't move into their pelvis. It's stuck inside the sacroiliac joint. So all the little nerves that are upset because that joint is rubbing around too much are numbed up by the medicine. And they can't tell the brain that they're upset. The brain relaxes all the muscles. The patient just notices dramatic difference in symptoms. So if they tell me it was pretty dramatic, they go from a 9 out of 10 to a 3 out of 10, an 8 out of 10 to a 1 out of 10, that kind of thing, then I'm convinced it's their sacroiliac joint. If they come back and say, I got to be honest with you, doc, I was numb in that spot where they stuck the needle in, but the deeper pain, the pain down my leg was still there, or I went from an 8 out of 10 to a 7 or 5 out of 10, that's not convincing to me. That is not the typical dramatic improvement I see after the injection when it's really coming from the SI joint. Now, that's not to say they're not having an SI joint problem. It's not to say they're not having pain. But what it's saying is that if I continue down this road and stop that sacroiliac joint from moving around surgically, I wouldn't expect them to feel much better. I might tell them, I'll take you from an 8 to a 6 out of 10 by doing this surgery, but I don't think it's worth it to get from an 8 to a 6. So that injection and that kind of measurement of the patient, even though it's a subjective measurement of the difference before and after the injection, is what really tips me over the edge into deciding it's worth it to get that joint to stop moving. So let's talk about now what are the options for that problem now that we've proved that's what it is. So the patient comes back into my office after the injection. They tell me it made it much better, and they described how much better it was, and I basically am convinced their problem is coming from their sacroiliac joint. What do I tell them their options are at this point? Well, they basically have 3 options. And these are typically the 3 options every patient has for every problem like this. But option 1 is to do nothing. Put up with it, try not to think about it. That's always an option. This is not some kind of emergency problem where your spinal cord can be crushed or you could be paralyzed or anything like this. This is mostly an arthritic, irritated, loose joint that's giving you pain. So option 1, do nothing, is a significant possible option for these patients. But to be honest with you, most of the patients, by the time they see me, are past that point. They've already tried nothing for quite some time, sometimes years of these symptoms. And most, if not all of them, are not interested in doing nothing. But it is option 1. Now, option 2 is called conservative therapy, and that basically means anything but surgery. And that includes, and is called pretty much conservative options, and that includes anti-inflammatories, Motrin, ibuprofen, Advil, Aleve, or stronger prescription medications like naproxen. And the reason anti-inflammatories are helpful is because the little nerves inside that joint that are upset because they're inflamed. They are instigating the inflammatory process, which is what our bodies do when they're injured or when there's trauma to it. And that inflammation stirs up irritation of the nerve roots, which tells your brain you're having pain. So anti-inflammatories can buffer or cushion or offset some of those inflammation symptoms and can make those symptoms feel better. It doesn't fix the problem. It doesn't change the muscle spasm problem that we talked about before, but it can maybe bring inflammation of a 6 out of 10 to a 4 out of 10. And if a 4 out of 10 is manageable and worthwhile and allows a patient to have a good quality of life, then using anti-inflammatories is certainly an option. And that way of thinking goes for all the conservative therapies. So anti-inflammatories, pain medication, muscle relaxers. Remember, all those muscles are tight in there because your brain's trying to keep that joint still. So muscle relaxers are helpful, and that includes things like Flexeril, Scalaxin, Robaxin, things like that. Physical therapy. You can attempt to strengthen all the musculature around that sacroiliac joint so that it's more stable in the natural setting. You have more tone in those muscles, and therefore the joint stabilizes more than if you didn't have that muscle tone. So that's an option. You can wear bands or braces that kind compress and stabilize the sacroiliac joint. You can just avoid activities that aggravate the sacroiliac joint, which typically are twisting and bending movements. That kind of fits along the lines of doing nothing kind of thing, but you're not proactively doing anything to the problem, but you're avoiding things that aggravate it. That's what avoiding motions that bother it mean. So that's an option. And then finally, an option would be injections. And as I said before, numbing injections aren't really worthwhile because they don't last. Steroid injections are definitely an option, and they can work pretty significantly, temporarily in the beginning. But the typical story I hear is that the injections become less effective and last less long as you take them more and more. You usually won't get anyone to do an injection like that with a steroid earlier than 3 months apart. So over time, they tend to stop working, but that's an option, injections. And then the final option before you'd consider a surgery are what are called rhizotomies. And that's basically, instead of sticking a needle in the SI joint that injects medicine, you stick a needle in there that gets hot at the tip of the needle, and that heat can burn the little nerves in the spot near that needle tip. That's not a permanent solution, but it can last longer than the steroid injections, and those nerves do grow back, but that can take a while for them to grow back. The real problem with considering rhizotomy or nerve burning for the sacroiliac joint is that the nerve plexus in that joint is fairly large. Remember, I showed you how big that joint was. So going in there with a needle that can get into the joint and then expecting the tip of that needle to really cover all the nerves that need to be burned is a lot to ask. So rhizotomies for sacroiliac pain is typically not very effective, or doesn't last very long, or long enough. But those are the list of conservative options. I can tell you that for the sacroiliac dysfunction problem, all of those conservative options are not very effective. And the reason for that is none of them address the primary problem, which is that the ligaments of the sacroiliac joint are loose and the joint is rubbing around too much. All of those options and conservative options really just treat the symptoms and don't tighten up that joint. So that's a good segue into the last treatment option, which is why typically people come to see me, and that's to fix things. So the surgical solution to this is a sacroiliac fusion. So let's talk a little bit about what sacroiliac fusion surgery involves. So we've proved your sacroiliac joint is causing your symptoms. You either are not interested in trying conservative therapies, or you've tried them and they're not working. You decide you want to pursue a surgical option. What is that option? Basically, it's getting those two bones to stop moving. So this is, relatively speaking, a new surgery. The latest techniques to do this are minimally invasive, which basically means everything's done through a very small incision in the buttock, whichever side your problem is coming from. And it's not done blindly. You're using x-ray machines in the operating room called fluoroscopy to guide your instruments to, in turn, insert, in the case of the system that I use, screws. They're somewhat like lag screws that go through the iliac bone into the sacrum and basically not only tighten those two bones together, but provide a conduit through which bone can grow, so that over time, when the screws get loose, or could get loose, they don't, because the bones have fused together. So what would be involved in preparing someone for that surgery? Well, once they agree to do the surgery, depending on their age and other medical conditions, we may need to get some kind of medical clearance, make sure your heart is okay, your lungs are okay, your kidneys work properly, etc. We'd get blood tests, an EKG, a chest x-ray to make sure all those things are working well, and that there would be no issues with general anesthesia, because you have to be asleep for this. And then you'd show up at the hospital, you'd meet the anesthesiologist, we'd bring you into the operating room, we'd put you to sleep, roll you over on your belly on a special table, and then do the surgery. So rather than kind of describe this in words, what I'm going to do is I'm going to shift over to a brochure that shows the surgical technique for the system that I like to use for this surgery, which is the Globus SI lock system. And we'll go over sort of picture by picture what's involved, and this will give you an idea of what it's actually like to do this surgery. Keep in mind, patients can present with bilateral sacroiliac problems, so sacroiliac problems on both sides. I will typically recommend they pick the one that hurts the most and do that first, and then I usually like to wait about a year until that side is fully fused before I put them through another surgery on the other side. After we go over the video of how to do the surgery, I'm going to talk about what's involved after the surgery, and it's a moderate recovery period, so I really like the patient to be fully recovered before we consider doing another side. In addition, just to point out, a lot of times a patient, let's say for example, will have right-sided sacroiliac pain, and because of that, and the pain is often severe, they will favor the left side, and because they're constantly putting most of their weight on the left side, it actually aggravates the left side sacroiliac joint. So what I'm getting at is you go and fix the right side and get that to be stable, and then it doesn't hurt to walk and put weight on that right side. Now you're lessening the extra stress you're putting on your left side or opposite side, and now the left side gets better. So the other reason I like to wait a good year before offering the other side is sometimes by fixing the worst side, you actually treat the other side also, and it gets better enough or good enough that you don't need to do the other side eventually. So that's just something to think about in patients who have bilateral sacroiliac dysfunction. So let's shift over to the surgical technique brochure, and let's go over what's involved in actually doing this surgery. So what we're looking at here is a brochure for the surgical technique for insertion of the Globus Medical SI lock sacroiliac screws. And that's SI lock, not L-O-C-K, but L-O-K. And these are the screws that I like to use when I do sacroiliac fusions. And rather than just describing what I do, we're going to go through this brochure because it really does a nice job of showing pictures of actually what happens in the operating room for this surgery. So this picture in the bottom right corner is, let's see if I can change this. In the bottom right corner here is an example of one of the screws. Things to note are the coating of the titanium here is a porous coating on the microscopic level. That can allow some bone to grow kind of into the nooks and crannies of this coating. The top of the screw head swivels a little, so that allows the contour of the iliac bone to allow the head of the screw to sit more flush. And then also the head of the screw has these little spikes in it which can anchor it into the bone a little better. And then here is sort of a translucent picture of the screws going through the sacroiliac joint. And the pinkish stuff in the center of the screws, and over here is the patient's own bone marrow, or you could use synthetic bone products to stuff the screw with this stuff to eventually get the bones to grow together. So let's take a look through the brochure and get to some better pages. So different kind of screws here. Here's a regular screw with the hole in the middle that the bone gets stuffed in. Here's a lag screw configuration, which means it's smooth on the top, threaded on the bottom, without the hole in the middle. Lag screw is mechanically engineered to pull two things tight together. So if, for example, the patient had a big gap in their sacroiliac joint, like for example in the injection part of this video that we talked about, you might want to use a lag screw there to pull those two bones closer together. But that's actually relatively rare. Usually the bones are already pretty close together, so you can use these kind of screws without the lag in it. Here's a lag screw configuration with the hole in the middle, and here is the shadows showing that the head of this screw swivels. So let's keep going, and again here's a picture of the screws going through the joint. and various configurations of screws that you can use. These are just the instruments that come in the pack. So here's kind of the first picture we'll go through of the start of the surgery. The patient is lying face down on the operating room table. This amount of skin exposed is really not what happens. There are drapes covering the patient, and there's like a little area right here, maybe 4 by 4 inches of exposed skin, and that's what we see when we do the surgery. The X-ray machine is this arc-shaped machine right here. It's called a fluoroscope, and this can be put in different positions, like you see here, to give you the different pictures that you need in order to know the orientation of what your screws are going to be doing. Without getting into too much detail, these are the 3 angles and images that we use to make sure that the guide wire, which is the first tool that's put through the sacroiliac joint, is in the correct position. You want to make sure it's not too high, too low, too back, too forward. The angle's correct. You want to make sure that the screws are not going to go into these holes here that you see, which are called the foramen, and this is where the nerves live. And these X-ray configurations allow you to do that, to make sure that what you're planning to do is safe. This is actually the shape of the lines that I draw on the patient's skin, which are some landmarks based on the fluoroscopic images that we get. And the entry point to the first guide wire is going to be right about there. And the guide wire is basically a stiff stainless steel wire with a very pointy tip that is going to puncture through the bone, and basically you're going to tap that into the spot where you want your first screw to go. And the screw has a hole down the middle of it that allows the screw to follow that guide wire. So if your guide wire is in the correct spot, your screw is going to go in the correct spot. So here's a picture showing through the incision, the guide wire going in. I don't use a drill to put the guide wire in. I tap it in with a little mallet. I feel I have a little more control over that. The incision is actually a little longer than this. We don't do 3 separate incisions for 3 screws. We usually do one longer incision. When I say longer, it's only about an inch and a half long to get the 3 screws in. Here's what the fluoroscope shows the guide wire looking like as it goes in. The entry point's into the bone's going to be about here. These are the other views on X-ray or fluoroscopic image of where your guide wire is going. And then after the guide wire goes in, you dilate up the tissues and muscles with these sequential dilators, smaller to bigger. And then once the biggest one is docked against the bone, you take the smaller ones out and you're left with this working space here. And everything after that goes along this wire or over this wire through this dilator. Let's keep going. So once your dilators are in, you now need to figure out what size screw that you want to put in. How long of it do you want to put in? And this gold-shaped measuring device, which goes over the wire and docks against the bone, in combination with the wire, tells you how long a screw you need. And this is what it looks like. On the guide wire is a little hash mark right there. You can see this black mark on this silver wire. And that tells you how long a screw you need if you want the tip of the screw to go where the tip of the guide wire is on the X-ray. So let's say on the X-ray, let's say this wire goes all the way in to about here, which is about where I'd want it. And that tip of the guide wire is where I want the tip of the screw to end up. Then I would pick, in this case, a 45 millimeter screw. There's 40, this is 45. And that hashtag tells me if I pick a 45 millimeter screw, the tip of that screw will end up where the tip of the guide wire is on the X-ray. Next, you take that measuring device out, and then over the wire you put a drill, and the drill basically creates a hole in the bone. I usually like to drill to just past the joint, right about there. And I don't drill all the way to where the screw goes. I let the screw create the space for that, because the bone inside of here is marrow bone, which is relatively soft. So you really don't need to drill all the way through. The screw can get a nice snug fit by self-drilling into that spot. So I drill to about just past the joint. Then when I take the drill out, I take it out clockwise so that the bone marrow in the threads of the drill stay in the threads of the drill. And I use that bone marrow to pack the hole in the screw with bone. So there's a little right-angled wire that goes into the screw while you're packing the bone, and that preserves the channel in the center of the screw for the guide wire. And then I pack the patient's bone marrow in this slot around the wire that I put in there, pack it in the threads, and then remove the wire. So now I've got a channel through the screw that allows the screw to follow the guide wire down to where it's supposed to go. But yet I've packed the space around that center area with bone, and I've packed the threads with bone. So the first screw then goes in over the guide wire, right there. You can see the wire, the screw goes over it, and in this case I would put the screw all the way down to about there. And here are the different shots on fluoroscopy that show what that looks like. Now I take the screwdriver out, leaving the screw behind like this, and then there's a special gadget that goes over the first wire to where the first screw is that will tell me the exact spot where I want the second wire to go to be the right distance between the first screw and the second screw. I actually don't like to use this instrument. I like to use this instrument. It doesn't adjust. It's like the perfect distance between the screws, and I usually use the 10 millimeter. So once that spacer guide is in over the first guide wire, I then tap the second guide wire in, again using x-rays to make sure they're in the right spot, remove the spacer guide, and remove the first guide wire. And now I've got the second guide wire in, and I basically repeat the steps I just described to put in the second screw. There are the dilators. There's the second screw going in. Usually that's shorter because the foramen is usually right at the end of that second screw. If we look at a really good outlet x-ray, which is right here, the first screw is going to be right about here, above the hole for the nerve, and then the second screw tends to be right at the hole, so it's going to be shorter. And then the third screw will be longer. So if you see here, the second screw is shorter. So you repeat the process for the third guide wire, and you end up with 3 screws in the sacroiliac joint. And those 3 screws stay there forever, and because I've stuffed bone through the slots of the screws, we get fusion in this area, which gets this joint to stop moving, and then the screws can never really get loose, and they just sit there and don't do anything once these bones have fused. And that is the surgical technique for putting in those screws, the sort of abridged version, the shorter version. Okay, so you've had the surgery, you're rolling in the recovery room. What happens next? Well, you're going to spend about an hour, hour and a half in the recovery room getting over the anesthesia. Typically, patients tell me they can immediately tell a difference in their old sacroiliac pain. That sense of discomfort, of instability, of pain with particular movements is literally gone after the surgery. They do, however, tell me that I replace it with something pretty significant, which is butt cheek pain. And it definitely, this surgery will definitely make your butt cheek hurt after the surgery, but I've learned a couple of tricks over the years that has minimized the amount of discomfort, and I now have some patients that say it barely hurts at all. Or if it does hurt, it's typically temporary. So what are those tricks that I do? Most of the tricks involve things that minimize bleeding, because my thought is that the main cause of pain in these patients after surgery was blood or hematoma formation in the gluteus muscles. You're putting guide wires through those muscles, you're putting dilating tubes through those muscles, you're putting screws through those muscles, and that stirs up some bleeding. It's inevitable, you can't avoid it. And a big ball of blood that then coagulates and is sitting inside your butt cheek muscles is going to hurt. So a lot of the tricks, as I said, reduce bleeding, and that includes things like injecting some numbing medicine into the muscle that also has some medicine that shrinks up blood vessels, injecting some synthetic material that seals up blood vessels. These are things like Surgiflow or FlowSeal. These are collagen-based thrombin products that cause blood to clot. So that decreases the bleeding. And then the last thing I do is immediately after the surgery, before the patient wakes up, I literally will take my gloved hand, turn it into a fist, and push down on that incision and just put a little pressure on that butt cheek muscle for about 2 minutes. And then in the recovery room, or should I say in the operating room before the patient wakes up, all the way while they're in the recovery room for an hour and a half after the surgery, is I'll have the patient literally lie on that butt cheek with a towel under the other side of them so that all their weight is pushing on that spot. Since I started doing all these things, dramatic decrease in butt cheek pain after the surgery. Anyway, 45 minutes, hour and a half in the recovery room, letting the anesthesia wear off. Then I'll typically take the patient, or tell the patient that they can go up to a regular room, and I'll usually keep the patient one night in the hospital. That first night, just take it easy. You're allowed out of bed to go to the bathroom, but that's about it. The next day, therapy is going to walk you in the hallways with a walker and teach you how to walk with that walker and not put weight on that leg on the side that we did the fusion surgery. And the hard part about this surgery is it's about 4 weeks of no weight on that leg. Then 2 weeks of gradually increasing weight on that leg, so that by 6 weeks after the surgery, full weight on the leg. So the next day after surgery, therapy walks you in the halls. The nurses will change your dressing. I'll come in around, or I usually come in around lunchtime. I'll look at your incision. I'll ask you how you're feeling. And typically what I hear is, my butt cheek's a little sore, but boy, that old sacroiliac pain, it's gone. And remember, some of these patients have had this pain for 5, 6, 10 years and have been misdiagnosed with low back problems or hip problems or other issues. So typically these patients are pretty happy. I'll let the patient go home. I'll tell them to stay in the house for a couple of days, not doing much. That doesn't mean lie in bed all day, but just stay home. They're allowed to go into the kitchen to get a drink or a sandwich. I'll let them go up the steps in the evening, down the steps in the morning, but I don't want them going up and down the steps all day long. About a week after the surgery, especially if it's their left leg left side that I operated on, I'll let them drive. If it's the right side, I'll typically say maybe 2 weeks of no driving. But it's tough to get in and out of that car with the walker. It's tough to rely on that right leg for stepping on the brake and the gas so soon after surgery. So I like a couple weeks before they drive. They'll be back in my office at 2 weeks for a checkup. I'll look at their incision. We'll get some x-rays, make sure the screws look good. I'll ask them how they're feeling, and if everything looks good, I'll let them start adding activities in. The movies, a restaurant, visit a friend for an hour, something light. But again, no weight on that leg, and using the walker or crutches. I prefer walker, but crutches are okay too, for 4 weeks. They'll be back in my office 4 weeks after that first visit, which will be 6 weeks after the surgery. Another set of x-rays, make sure the screws look good, make sure the incision looks good, make sure the patient's feeling good, especially now that they're walking on putting full weight on both legs. And then if everything looks good at that 6 week mark, I will bring them back 6 months after the surgery with a final set of x-rays. If they feel good and look good and the screws don't look loose on the x-ray, which means there's like a halo around the screws on the x-ray, a shadow or dark spot, then I'm pretty confident that that SI joint is fusing nicely, and I will release them from my perspective. If they came in originally with bilateral sacroiliac symptoms and we operated on the worst side, I'll tell them wait another 6 months, which will be a year after the surgery, and if that other side is still bothering them, I'll bring them back into the office. We'll get a CT-guided injection in that other side, prove that that is where the pain's coming from, and then I'll do the other side at that time. But I like to give them a good year after the surgery on the other side to see if we can make that opposite side get better on its own without a surgery. So that's typically the post-op care and time period for a sacroiliac fusion. The last thing to mention before we kind of wrap up the video are the risks of this surgery. Now, there are 3 risks for any surgery. It doesn't matter what kind of surgery it is, same 3 risks: infection, bleeding, problems with anesthesia. Now, these are all relatively low, especially for this kind of surgery. It's not a surgery that takes a long time, so the anesthesia risk is generally on the low side. Even though I mentioned that bleeding can cause pain after the surgery, the risk of bleeding where it could be something serious as far as a complication is concerned isn't the kind of bleeding I'm talking about. This is just local bleeding where the surgery is. So this surgery is not really near any big blood vessels that you have to worry about. So that's a low risk. And then infection, same risk for anything. That's why we do the surgery in a sterile operating room with gowns and gloves and masks, and the instrumentation is sterilized. But even though we do, and also I give antibiotics before and after the surgery, but even though we do all those things, there's still a small, probably less than 2% chance of infection. Typically, if that happens, it's usually a superficial infection on the incision, and that's just treated with antibiotics. Now, there are a couple of risks that are special to this surgery because of where it is. And basically that's involved with putting metal hardware into bone. So the primary risk there is fracture. And that's why I typically will not offer this surgery on a patient who has osteoporosis. And if they do have osteoporosis and they need the surgery, I will recommend they get with their primary care doctor to get on some osteoporosis medicine. And then they would need a close to normal bone scan before I would be willing to do the surgery, or bone density test. The other risk is that the screws could be too long and you could get into those foramen where the nerves come out. That could cause problems like spinal fluid leaks and headaches, as well as irritation of the nerves that live in those areas. Knock on wood, I've never put a screw in someone's foramen, but it's in the book, so I have to tell you about it. And those are basically the 4 or 5 risks to that surgery. Again, very, very low risks, but they're in the book, so I've got to tell you about them. So that's pretty much it for the video on sacroiliac dysfunction. I forgot I had one of these on my desk, so I thought I'd show you. This is an actual SI lock screw, just like the picture. You can see the hole in the middle that the guide wire goes down when you use that to move the screw down. There's the head of the screw that wiggles. There's the slot in the screw. And then if you look really closely, you can kind of see that rough coating on the titanium. That provides little nooks and crannies for bone to grow in. So that is an SI lock sacroiliac screw. So I hope that video was informative. Thank you for tuning in. Thank you for watching. If you think this video was helpful and helped prepare you for your visit with your neurosurgeon, or just educated you about the sacroiliac joint, please hit the like button. Please subscribe to my channel. I've got other videos on various other neurosurgical topics. Feel free to look at those, and more videos are to come. So again, thanks for watching, and don't forget, stay healthy.